Namaskar, my name is Vivek Sharma. I'm a social entrepreneur and I talk about mental health and cancer, as you know, on various platforms. And it's my honor today to have eminent panelists with me to talk about AML, acute myeloid leukemia. It's a disease called blood cancer. And why I want to talk about AML today? Because as many of you might know that we run support groups, patient communities in different cancer domains, and recently I could connect with 4 or 5 families. Those were affected with AML, and unfortunately, like in 3 to 4 months, uh, 4 of them they died because of various challenges, of course. And this is something that triggered something in me, and I thought that why not discuss it at a bigger platform with the key relevant people and think that what we can do and how we can do further. So we have today Amit Shenoy. He's a AML survivor who has undergone bone marrow transplant. We have Dr. Ashay Karpe. He's a medical hemato-oncologist. We have Aurelien Breton, who is managing director of Servier India, a company that is into the manufacturing of cancer drugs. So let's welcome all of them and let's talk. First of all, thank you so much, everyone, for having your time scheduled for this interaction, and it is going to be very precious kind of interactions because this is something an area you all would agree that AML is one disease that does not give time. That's what I have heard. And today I'm going to validate with all of you and see that what are the things that taking or will take to improve the situation in our country. I'll start with Amit because Amit, you are a survivor proudly, and I'm so grateful that you carved out some time for us for this interaction. So understanding AML, because it's kind of in when I was studying in the class 5 6, I was told about a story. There was a elephant in the room, and people were blindfolded. Children were blindfolded, and they were told that touch the elephant and tell what elephant looks like. So somebody who touched the trunk, he said that elephant is kind of cylindrical. Somebody who touched the stomachs, he said that it's a very big kind of thing. Somebody touched the tail, they had different explanations. So AML to me in today's scenario is like that. So what has been your experience being a patient, having gone through the entire journey, kind of battling things? How easy or difficult was the navigation? How it impacted you emotionally, socially, financially, and how it went across? Like, if you can tell us in detail.
Hi. First of all, thank you so much for having me here. So I was detected with AML in 2018 August. Uh, Actually, it was very incidental that it got detected during a root canal. I had actually broken one of my tooth when biting into a peach. So the teeth got lodged into the peach ridge and it broke off. I went to the dentist. The dentist made me do a root canal procedure. 2 or 3 weeks later, the bleeding wouldn't stop. So she said, do a CBC and come. I did my CBC. So my family has a history of cancer. My grandfather passed away because of esophageal cancer. My father was detected with pancreatic cancer in 2020-21, and I was detected in 2018. So incidentally, it so happened because I have a habit of going through reports. I can read reports, being a microbiologist by profession, and I thought that something is wrong. The blood is not stopping, the clotting is not happening as needed. So I visited a hematologist, a close friend of ours, family friend of ours, and he told me that why don't you repeat your CBC after 21 days. Then came first week of August, wherein I was detected with full-blown AML, 60% blast cells, and I was told to get admitted in 2 days' time. That was one point where they were saying that the ground shifts from your below your feet. So that's the condition I was in. And I had gone to the doctor along with my wife. She jokingly told me that you keep on reading stuff and It's not what is being shown in the report, so it might be something different. So she laughed about it. I said, I know what is wrong. You better confirm it to the doctor. So I got admitted 2 days later, and in those 2 days, I had to have a word with my family, tell them that I need to undergo treatment. The doctor had told me that you would be out of gear for at least 6 months. At least was the underlying word. So got admitted. Did my the doctor did my bone marrow biopsy, that was, and what was confirmed by the peripheral blood CBC was confirmed with the bone marrow biopsy. So that is how the whole induction started. 2 days later, on when a PICC line was inserted, that was a 7+3 induction, daunorubicin and cytarabine. So 14 days post, they did another biopsy to check whether the treatment has worked. 25% blast cells again. So doctor said, see your bad luck. If the induction doesn't work, I'll have to give you a regimen that is normally used for relapse patients, which is a picked up protocol called as flag ID. Oh my god, the battery of drugs that went into my system, I was totally hallucinating. Um, One night, I almost lost sensation in my right leg. The doctor had to be called in. A lot of things happened. Later on, due to some negligence, I don't want to point out anybody here, when they were washing the PICC line entrance, some amount of moisture went inside, and as a result of which, since my immunity was already low because of the chemo, I caught a fungal infection. And the temperature rose in 3 days' time to 104.5. I had to be rushed to the ICU and kept in total isolation from everyone. Thankfully, my doctor then allowed me to carry a mobile phone with me. I think I was one of the fortunate ones to have a mobile phone with me so that I could communicate with my wife. So I was rushed to the ICU with a temperature of 104.5. Thankfully for the doctor, he allowed me having a mobile phone with me. One of the few patients allowed a mobile inside the ICU to communicate with my wife. That's how we could communicate with each other. And my wife was there 24/7, being my pillar of strength when no one was around in the hospital with me. Father, who had already undergone a liver transplant at that point in time in 2016, was not advised to come and sit in the hospital nearby. So it was a very precarious condition that was present at that point in time. A lot of mental battles were being fought as to whether I come out of the ICU, whether I make it through the therapy. But constant talks with my wife on the phone made me calm. And yeah, that's how I pulled through the process of infection, the fungal infection. Later on, I was made to undergo a bone marrow biopsy after 28 days, and thankfully, the flag ID had worked. So I was in total cytogenetic remission, as they call it, meaning I was free of even minimal residual disease. Then came the process of finding whether I am a low risk, intermediate, or a high risk. So they did those fish studies, as they call it, immunofluorescence based, and found out that there was uh, a very intermediate risk because there was sole 9q deletion, as it was very rare at that point in time. So I wasn't told to undergo a bone marrow transplant. So the problem of finding a donor in the family, since I was the only child, I had no siblings at that point in time. The cousins, being a haploid match, were no good for my transplant. And as a result of that, I had to find a full match donor. So we approached one of the largest bone marrow registries in India, that is called DATRI. And thankfully, they did they came up with 12 full HLA matched donors for me. And on 23rd of November 2018, one gentle soul, thank him a lot, agreed to donate his stem cells. And at that point in time, so the story goes here and there at times. So at that point in time, the hospital where I was getting a chemo did not have a BMT ward. So I was told to undergo a bone marrow transplant at the doctor's colleague's hospital in Pune, which had a good history of successful BMTs. And I had to be rushed to Pune after having another consolidation therapy, HIDAC therapy for 15 days, and then later on shifted to Pune for my transplant. During this whole process, there was a lot of financial toxicity that happened. Since my father had undergone a liver transplant, a lot of funds had already drained, and thankfully at that point in time, my insurance cover was 15 lakhs at that point in time. 50, so it's almost 1.5 million. That got extinguished. So the problem of my bone marrow transplant, which was supposedly to cost me 4 million at that point in time. So one of my wife's relatives said that why don't you go for a crowdfunding? So she approached a platform in India, well known for everyone. I don't want to name it. And we started posting messages on appealing members or her friends to
Raise the funds.
raise the funds.
Yeah.
Thankfully, many of my school friends, her colleagues, could raise that amount in a quick period of 8 days. That has been a record for crowdfunding on that particular platform. Post which I was shifted to Pune 6th December 2018, made to undergo another heavy regimen with fludarabine melphalan. I was part of a clinical trial, which was for which I had to sign informed consent form. After that, I had a severe bout of mucositis, which is inflammation of your mucous tissues. I bled through my mouth, and sorry, I'm pointing this out. But at that point in time, I didn't know how bad it would be. So that moment passed. On 13th of December 2018, I underwent a bone marrow transplant. All thanks to the donor who agreed to give me my stem cells. And later on, 43 days post that, I was discharged. During that period, I was detected with grade 3 gut GVHD. Was made to undergo a colonoscopy, which thankfully took the GVHD away. The preparation process for the colonoscopy took the GVHD away. And thankfully, after that, I'm here and what I'm.
Thanks, Amit. It's very overwhelming actually to understand the entire journey, and it's quite painful. But the only good thing is that you made it and you are here with us. So there is a theory or kind of perspective of keyhole, process. Like when you look at something from or kind of a keyhole, if I'm looking at it from a distance, it's just one small hole. But if I put my eyes into this, the entire world is there. So that entire world can be explained by a clinician who sees, like, for us patients or we the patients, it's just one doctor. But for a doctor, it's kind of a community. So, Dr. Saab, let us know that what is your perspective about AML, its incidences, prevalence in India, the kind of treatments available, how truth it is. Like, I was telling in the beginning that it's kind of an elephant. How real is that elephant?
Yeah. See, I'm in this field for now almost more than 18 years. So I started my career as a hematologist. So to begin with, in 2007-8, when actually my first-hand information, I got about AML that time. If I compare with all other malignancies, if I take all other cancers, the blood cancers, they contribute almost 2 to 3%. While if you look at the Indian statistics in 2024, almost 20 lakh new cancer cases got diagnosed. So you have to understand 2 to 3% of it is a blood cancer. But blood cancer comprises of myelomas, then lymphomas, you have leukemias, you have ALL, AMLs, everything. So incidence of AML is almost 0.8 to 5 per 1 lakh population in India. If you contribute, so that will put around at least 75 to 80,000 new cases every year. And I'm saying this is documented because you don't have formal cancer registry, and now a new government policy is going to make cancer as a notifiable disease. So once we have that, probably we will have a better statistics. There is a whole lot of patients who don't even reach beyond primary healthcare facilities where these things remain suspected. And as you know, amidst if you look at the journey, and most of them will not be even able to make that journey. So that is something which is important. But in this field for more than 18 years, I can tell you the scenario is pretty much changing now. Like 2007, when I was there, I will tell you, even I was involved in the part of diagnostics. That time, a technique called flow cytometry, which is required for diagnosis, was not easily available. We used to do a fluorescent microscopy. I was myself was trained in that. But now it is, with the flow cytometry, it is easily available across. Uh, as even if you had heard Amit Shenoy, he would have said, no, okay, there is a, like, whenever somebody gets a cancer, you ask a simple thing, what was the stage of the cancer? While blood cancer, they do not have stages. What you ask is risk stratification. And what is risk stratification? Because that is one of the most important thing in making a treatment approach. So there is a low risk, there is intermediate risk, and high risk. It is purely depending on the different genetic markers. Genetic, that doesn't mean hereditary. What it means, that why somebody got a cancer, number one, what was the mutations or the genetic change which is driving that cancer. So why this is important? Because based on that, you take a treatment decision whether this patient can be purely cured with chemotherapy alone, or second part is that now there are targeted agents also. So many targeted agents have come up. We have FLT3 ITD, we have IDH, or many other mutations which are there. So you require specific drugs. And the third group is that where you know that your chemotherapy alone is not going to cure it, you will require to do bone marrow transplant, like the way Amit underwent. So point was that, I was myself in Mumbai, so it was so big that time to learn a transplant. I actually had to go to Pune in 2007. Now, though we have at least 8 or 10 bone marrow transplant centers in Mumbai itself. That time it was pretty rare. Now there are very few institutes because I was myself interested in stem cell transplant, so I was trained in for that in for 5 years. So that time, but now it is more and less are approachable to everybody. Only problem comes in, when to refer that exactly at a point of time, number one. Second thing is, a proper guidance by a trained doctor. And the third thing is finances. It's a huge toll, like among all the malignancies, because I've also done medical oncology, I also treat solid tumors. Among all the cancers which I treat, the AML is one of the costliest malignancy to treat, number one. And the thing is that looking at the results, the results, when I treat AML in younger patients, my success rate is in that, 60 to 70%. Means what it means that it's just not, controlling the cancer at a particular point of time, but we always say it's a 5 year survival rate. Means if I take 100 odd patients and sit at five, I tell them, you everyone go around and take a standard therapy and return to me after 5 years. So if they're young, 50 to 60% of the patients they will return to me. But the moment you become 30, 40, and India also in elderly, because if you look at the AML, it is elderly disease. So there you have a lot of mutations and more like high risk. Then my success rate dropped to 20 to 30%. It is as bad as that. But I will say, looking at my journey also in the oncology for last 17 to 18 years, there's a tremendous developments which have happened. But still, yes, the challenges are still there. But I think as like as a country also, we are actually now the focus is on healthcare now. If you really look at the recent budgeting and other things, I think there is a hope of light. But again, it's not only India. When you look at it, it's a global problem, and there has to be global solutions. And but thanks to the various MNCs which are bringing this latest technology and latest drugs to India, so that they are become more accessible, number one, and like many of the patients can be benefited. So definitely that is going to affect the cure rate in the long run.
Thanks for the fantastic overview, Doctor. In fact, your communication or the talk has triggered a lot of questions in my mind. I'll hold my horses for some time, but I'll come back certainly on that. Meanwhile, let us know that you mentioned about the age groups. Like what are the high risk age group and what are the relatively low risk age group?
Yeah. So the thing is that the age group has multiple things to do with it, because somebody gets in the younger age group versus somebody gets in the older age group. The basic difference is that, in the young, you don't have multiple diseases. While the more you grow old, like 60 plus, you will have a lot of comorbidities, what we call. You can have a diabetes, you can have blood pressure, then you can have heart issues, so that really, I cannot give all intensive treatment. Second thing is that when somebody gets older, what we see as a disease biology of acute myeloid leukemia, they have a lot of mutations, which actually puts the AML into high risk category. And what it means that, some time back I told you that in AML we have a risk stratification. There is no staging. So low risk means what? There are certain genetic change are there. We say translation 822 means a part of chromosomes of 8 get detached and gets attached to 22. Or there's certain normal karyotype, means you don't have any genetic abnormalities. They will come through something like a low risk or a low intermediate, what we call. But the moment you have some genetic abnormality in your blood or blast, which actually defines it as a high intermediate or a high risk, so that puts a person into a high risk AML, which is actually where the bone marrow transplant or stem cell transplant is warranted. Plus, they might require some targeted agents based on their genetic abnormalities, like FLT3 is there, you have midostaurin, you have gilteritinib, you have IDH1/2 inhibitors, which are there. So all these things that needs to be given. So the more the age, more are the chances that you will have a high risk cytogenetics. In the younger age group, the cytogenetics may not be high risk, number one. And the thing is that they have better tolerance to the drug. So that is how the age group, really affects. But if I look at the age group of less than 15, AML is not common. There is another cancer called acute lymphoblastic leukemia is pretty common. Almost 90% of the patients will be having that, which has most with the newer regimens 100% cure rate. So I just always keep hoping, AML will have something like that. But the thing is that now we are understanding biology of AML. It is not a single disease. Actually, it is multiple diseases which are clubbed together.
Awesome. We'll discuss more about the challenges in AML. Meanwhile, let me reach out to Mr. Aurelien Breton. Correct me if I pronounce it right.
Perfectly well.
So you are managing director of Servier in India, and Servier is it's a pharmaceutical company that is into drug manufacturing for cancer. How had been Dr. Saab has mentioned about the global local solutions. So because AML, I think it is a worldwide disease. And how had been your experience? Like, how much you have seen AML, and what do you think that has been the evolution of the drug in the world?
No, I guess globally speaking, maybe not fully answering to your question, but more largely on the challenges in terms of AML management at large in the country. I think you were kind of illustrating the point that is diagnosing AML is not easy. I mean, the first symptoms going to be fatigue, going to be potentially infection, going to be bleeding, as you were speaking about, and if patients will have social understanding, social network, education like you to understand that there is really something going wrong, they're going to help them in fast tracking the solution or the path towards the diagnosis. But if that goes to primary care physicians, potentially not in the big metros, the big cities, but more in rural areas, then naturally physicians will want to exclude some of the classical diagnostic, especially if it is around the infection. So there is a lot of time that potentially can be lost in identifying the disease, putting a right diagnostic on the disease for these patients. So I guess that there is globally a need to train physicians, healthcare professionals at large in the country, but everywhere in the world, I can tell you, in order to identify better the symptoms, do the right diagnostic relatively rapidly in order to put that diagnostic on the patient, in order to accelerate the care to or the path to treatment. Again, by the way, for the country, when you have patients that are situated in rural areas, far from the big cities, it means that they have to go to the metros. Not easy. long, complicated, expensive. I mean, from what you were explaining, we understand that you spend not even weeks, months in the hospital, living in the hospital, potentially even isolated entirely in a bubble to protect yourself. Very complicated. Not only there's a diagnostic step that is needed, but there's also like all the testing, genetic testing that is required in order to well qualify the disease, and then after to have the right treatment that is to be given. So I think there are like multiple areas where, globally speaking, the whole healthcare community, physicians, of course, patient associations and NGOs like you, but also the pharma companies have to work together in order to increase the level of education, sensibilization of people around the disease, its management, and to recognize it, and also to improve the speed to diagnosis and testing, and the speed to access to the right specialized physicians like you, in order that patients they can be well treated and well managed. I would say from a pharma standpoint, and I'm not only speaking from my company perspective, but I think we really see our role to contribute to that, contribute to the improvement of the overall healthcare environment by finding new drugs, by finding drugs that are kind of a breakthrough treatment. I'm afraid in AML we are not fully yet at 100% curative yet, though there are many things that are progressing over the last years in terms of testing, in terms of drug, in terms of taking care of patients at large. So things are progressing, which is good. But unfortunately, pharma and medicine, this is a long journey. I just wanted to add maybe one point regarding infrastructure. So when we look at the infrastructure in the country, definitively, you have a specialized center in the big cities, in the tier 1 cities, and then things are becoming a bit more scarce once we go to the tier 2, tier 3 cities. And I guess people could potentially complain against that, and I would also understand that. Being a foreigner, arriving in the country only a year ago, having an experience from other countries, I can tell you from what I see of India is absolutely amazing. Because if we look at the photo, potentially people could complain that there are still a lot of things to invest in the infrastructure. When we look at the movie, meaning when we look at what happened over the last 10, 20 years, what is about to happen over the next 10 years in terms of investment in number of physicians, but also in terms of infrastructure, which means center for testing, center to take care of patients. This is absolutely amazing, right? I mean, that goes along with the economical development of the country. But it's really, really impressive to see overall the investment that is put by the country into its healthcare ecosystem at large. So at the end of the day, it is an ecosystem, an investment, right? It's investing in people in order that people will have a better life in the future.
Amazing. Thank you, Mr. Breton. It was really overwhelming, understanding about the global perspective about the availability of the treatment and the kind of commitment that the industry per se is showing in finding the right solutions for the AML. I'm coming back to you, Dr. Ashay, and Mr. Breton has mentioned about the infrastructure and other things. Okay, one thing is that we have got the hospitals, we have got the setups and everything, but how easy or difficult today it is for the tier 2 or tier 3 cities to diagnose AML, early and kind of provide the treatment, and what are the challenges in managing those patients or those cases, and very importantly, relapse cases.
Yeah. So as Mr. Breton has pointed out, it's a training of all, even the primary healthcare physician. It is just not, what we are having is sometime back I said, timely referral to a specialist. That is something which is the most vital thing. And how much time is elapsed from your symptoms, still you are reaching a point of excellence, that what determines his outcome. So maybe training of, at all, district health center, or maybe have rural health center where, you would have heard Amit's speech, CBC. It's a very simple, elaborate investigation. You don't even need a fancy investigations to be done. If you have a good, complete blood count, I think that is more than enough to suspect or diagnose a blood cancer. Definitely, you can have all other, technologies like flow cytometry, you can have FISH, you can have NGS now. Now that we don't do molecular tests, by PCRs, with used to, and there used to be long waiting time, you till you get it. Now with NGS, you have the results within 7 to 10 days. And majority of the cities, definitely metros, we have a, privilege that you get this test easily available. But even now in tier 2 and tier 3 cities, you actually have a very wide network of this test. But again, the point remains, these are one of the most expensive tests you do. Like in acute myeloid leukemia, if I start only a diagnostic battery of tests and I have to do in an ideal scientific manner, it will cost not less than 75,000 rupees to 1 lakh rupees minimum. That is what I'm
Just
saying.
to ascertain
I'm
that
saying
it
a
is
diagnosis, a proper diagnosis in the scientific manner. Only to diagnose AML, you require a complete blood count, which is 250 rupees test. That is not a very big, but if I have to diagnose it and I have to treat it the way scientifically I should completely do elaborate diagnosis of AML, this is something which is there. Easily available in tier 1 cities. Now, most of the cities, like in Maharashtra, if I have to take it, Mumbai, Pune, Kolhapur, Aurangabad, Sambhajinagar, what we call Nagpur, everywhere you have this test available. It is not that, or the pickup spots are available. That is the best part of this country. You have not accessible, but there are certain pockets which are still not accessible. But point here remains, a primary physician should suspect first. So the training at the primary point of physician, that's something which is the most important thing. Because even when you hear Amit's case, there was some dental thing is there and it was not healing. So, you just went back. So doing a CBC upfront would have done the job. But, that is something which is more elaborate. So the point here is not just a technology, but I think awareness, which Mr. Breton pointed out. Unless you have awareness, this is just not possible. And then thing is that you have this referral system, from where a primary physician to a institute, we can have a regional institutes. Because I think if you have visited Tata, you would see, you have 80,000 new cases annually registered, which is for a single institute is difficult to cater.
correct.
So creating more hubs like this, and lastly, this is not a single day procedure, like for 5 days you go somewhere. Now, somebody who has to travel from, say, a rural area, for them, when we set it, we see that it's 6 months treatment, 8 months treatment. So somebody beyond patients, there is also caregiver, and there is a loss of wages we have to consider to account for. So whenever we study health economics, it's just not a treatment cost. It is a quality of years, lost by the patient because he was in the productive age group, versus plus you have to account for those who are caregivers because they also cannot go to their jobs, or that is also. So we have to consider this economics when we are treating. So creating, but it's not practically possible that you have a BMT centers because that is will not be required for all of them. But at least we could provide this kind of care. I think most of the job will be done. But as Ms. Bitan pointed out, it's now we are having more awareness, but still, if you look at less than 2% GDP spent on the health sector. Okay.
Correct.
So now the newer government policies, I think, probably will come into play. I think they will do a better job, but I think it's just the beginning. So definitely we are looking a very positive way forward.
Dr. Saab, we all agree that financial toxicity is one of the biggest, challenges in the treatment or even the diagnosis of AML correct way. Of course, like very unbiasedly, like there are, or rather, I may be very biased or might seem biased, like, but still, there is one section of the society, those who can afford everything.
Yes.
Okay. And a relatively very lesser kind of population that can be helped through various, support and all that kind of thing. But if at all we think of, because you mentioned about that, okay, CBC is one kind of parameter that can detect AML early, but then if you have to do it scientific way, it is going to cost a lot.
Yes.
India is considered to be the country of reverse innovation. And do you think that personalized treatment or these therapies would ever be possible in the near future?
Yes, definitely. So right now also we are having a personalized treatment. So I'll be very honest with you, Vivek. If I'm seeing 100 odd AML cases in my OPD, then only 10% of the patient, I'm saying 10% of the patients, I'm able to treat in the scientific manner with the guidelines, which recommends whatever the targeted agents to be given, or, there are certain AML which should be transplanted in first remission, what we call. You said about relapse, but there are certain things that how I can prevent a relapse. That is always here, because if I treat a newly de novo AML, what we call, versus AML which is relapsed, in de novo AML, your results are better 2 to 3 times better than the relapse one. So in a de novo AML, my success rate is 40 to 50%. In the relapse, it will drop to 20%. So it is that bad. So I will see to it at the first point of contact that how I can optimize my results. So definitely we are heading for a precision medicine. And I'll give a simple example. I think when I was a student, way back 2007, NGS was practically, the next generation sequencing. Now we have like third generation Sanger sequencing, fourth generation. But that time it was practically unheard of. Somebody would have got a whole genome sequencing and has got $100 million at the beginning. Now you can have the same test, which can be done in as cheap as 25 to 50,000 K, 50K. It is that much less costing is there. So at this juncture, I can do these NGS, and these are easily available in India across. And the thing is that the sample also, previously when used to send this test, the fragility of the sample, if till it reaches lab, this used to be a lot of questions. Now the logistic by also has become a better. But the point here is not just to make a diagnosis, but point here is that, as you said, a precision medicine, what it means, if I'm able to diagnose a XYZ genetic condition or at a point mutation, whatever I'm saying, but I should be able to afford the drug for the same. Or second thing is that availability of the drug. Even if you said, there is a section who can afford, there was a point when we need to import these drugs from abroad, so there is used to be some lag time, to get these drugs. So all these things are getting minimized, they are getting better and better over the period of time. That's the reason I say we are going toward the era of precision medicine, just not in AML, but in all oncology section, that we are going toward a precision medicine. Now there is no generalized medicine per se, but yes, these things are pretty costly still now. But if I compare what was there in the past, definitely scenario is much better.
Amazing. Quite spot on, actually. Now, let me come back to Amit. Uh, right, like, you all would agree with me that there are a lot of things that we don't even talk about cancer. Like, for example, everybody is talking about treatment, life. But what about quality of life? What if, like, I'm alive, but I'm not able to feel like I'm alive? What had been your experience when you mentioned about the isolation, the mental, stigma, or kind of a taboo? You, on a lighter note, you lived COVID thing before even COVID hit the country.
Yeah. I would say that because it's total isolation, and you're not even allowed to meet your own father and relatives. So it was double door entry isolation, and one of the few isolation wards I've been in. So even when I had to my wife had to take my plate of food, it used to be kept outside, and by the time it came to me, it was cold. So we had to tell the staff nurse to put a microwave inside the room so that
Yeah.
the food could be heated and given up. Neutropenic diet, as I talk of, which is essential to uh, live through chemotherapy so that you have least of infections, is very stringent as of, because you cannot eat any salad which is raw. Everything has to be cooked. You can't even have stale food. Meaning that is refrigerated and heated up the next day. Even that is not allowed, because there arises the risk of any bacterial contamination that could occur when the food was being transferred from A vessel to B, and which hand was used. So to prevent all that, anything that is made on the stove could be transferred to the tiffin and then brought to the isolation room where I was kept. That was point one. Point two is, as you rightly said, isolation and fear. Thankfully, in the isolation ward, my wife had a bed close to my bed, and she was totally under the gown and
Mass
Very, very
effort,
similar to
yeah,
COVID kind
yeah.
of. Because as you rightly said, it was prelude to COVID. We used to joke around. What if we are here for long? How long will it take? So, on an average, if I tell you, every hospitalization of mine has been 49, 40 days, and my last hospitalization is 49. So, a cumulative 138 days of hospitalization. So, that's how bad AML treatment is. Because even the slightest amount of infection can ruin you inside.
Mhm.
It's constantly under a lot of antibiotics.
Right.
God forbid.
Well, Amit, you spoke about one aspect of, because for many of us, like it might not matter even. Okay, the cold food and all like in general life, we don't even think of it. But when you are bedridden, when you are isolated, these things become, like kind of trigger to the depression, could be, or stress at least. Uh, we talk about treatment, we talk about things associated with it. Okay, like for because of people like you and me, we are talking about mental things, mental issues. How about the work loss? How about the sexual wellness? How about the societal kind of pressure or stigma, taboo? Lot many people are not even talking about it. It's not a kind of point to them.
Rightfully said, because cancer is considered to be very stigmatous when talking about the Indian context. Many people talk of it as bad karma, but it's not bad karma. People have a lot of myths related to cancer. It is not karma. It is not something that you've done in the past that has come to sting you in the present life. It is not. It is sheer bad luck or circumstances which or kind of lifestyle that led to cancer. I would not rather it is awareness is need of the hour when you really want to take the stigma away from society, and that's where cancer awareness plays a vital role, mainly in the Indian pretext. So, as I said earlier, I was working for an NGO and I did hospital audits for readiness for organ retrieval. That's when my cancer diagnosis happened, because it could have been stress related, it could have been various parameters, because I was working in Nagpur at that point in time doing my audits, and soaring temperatures 45, 50 even. So that could have triggered is what doctor said, but sheer bad luck. I repeat my words. So when you talk of all these things, there are numerous triggers. So even after my chemotherapy happened, nobody in the hospital told me that there would be long-term side effects. The, the last chemotherapy I had triggered what do you say? Chemotherapy induced peripheral neuropathy. So I developed ulcers on the bottom of my sole. On the bottom of my sole, what am I talking? So ulcers on the sole of my foot. And till date, I am on nerve relaxants in order to take care of the neurotic pain that happens. When it comes to sexual health, yes, it took a very bad toll.
Job loss is there.
Job,
Are you
job.
able to get back to the mainstream?
No, no, not currently, because given numerous interviews, all of them say, I'll get back to you. I'm 41 right now, but
And they don't get back.
they don't get back. They don't ever get back. And there's also a lot of stigma when it comes to hiring cancer patients. That's what I've heard from somebody in HR, that it affects our insurance. So if we can't put you under insurance, how can we hire you? That needs to stop. I think in France they have the right to be forgotten. That needs to come in India. That needs to come in India, because your past medical history should not have a binding on job opportunities for anyone in the near future. For that matter, even insurance companies, when I talk about insurance, there are companies who don't want to offer you insurance for the fear that they might have to pay out if you have a relapse. I mean, I had to take a sabbatical from my workplace, and it's been savings done by my father, and thankfully, my wife has resumed work right now. And so that's how everything works in the household.
It's very unfortunate to hear that because, today here we are talking all these things in front of camera, but we are all interacting with people, survivor, and we know pretty well that it is really difficult to get back to the mainstream. And you rightly mentioned about the right to forget. We must have that kind of moment in India. We are trying to help our way, whatever way we can. Well, many of the times when we have fever, Dr. Saab, you would agree that people do not come to you directly. I got fever and now let me see the doctor. They do that putty thing, they do some by bathing and all that kind of thing. After that, the fever is not going, then they come to the doctor. So then doctor gives them systemic treatment. Either you pop some pill or take some injection or something. So for that systemic changes, I would come to Mr. Breton and let us know that because you have traveled the world, you are managing a corporate. What are your opinions about access and collaboration when it comes to AML, and not only AML, otherwise it should be like, I'd be biased if I say that it is related to only AML, but yes, otherwise in general about cancer, how should people collaborate better on a larger scale and can get back to their normal life?
Well, maybe to start, we say that there is a need to have education of the whole healthcare community. But once we have said that, I think I'd like really to thank the three of you today, because saying it is one thing, taking time from your all busy schedule to come and to have that discussion to be then popularized on the social network in order to have many people to watch it and to be educated, I think this is really a great thanks to all of you. I would like really in particular to thank you because it is not only about commitment, I think it is about courage. I think what you've been sharing is about having a lot of courage, sharing what you've been through, sharing your personal experience and the consequences of the disease. And you speaking about the stigma, I think having the courage of expressing openly, freely in front of a camera of the journey that you've been through, I think going to help a lot. People to feel less stigmatized, to have people to better understand what the disease is about, and to express more, compassion towards, unfortunately, the many people that are going to go through cancers at a certain point of their life or within their relatives. So I think, I guess from a pharma industry standpoint, that would be physicians and the industry. I think some years ago, till some years ago, we were very focused on hard endpoints, hard outcomes. We were looking at progression-free survival or overall survival, kind of a very medical parameters to assess the quality of the medicines. Things are changing. Things have changed a lot. I mean, in Servier, for instance, we have a patient advocate, meaning whatever clinical trial we organize, whatever even material that we develop, we'll have it reviewed, discussed by patients that have gone through the disease and that are capable of saying, okay, this is nice, interesting, good, these outcomes, but you also need to look at that and that. Or doing the clinical trial this way, potentially not going to fully assess the efficacy of the treatment on that aspect of the disease. But these are important. Typically, quality of life, as you were saying, because surviving is good, but if it is with a very poor life condition, that has to be evaluated and taken into account. So having close collaboration, partnership between patient association, NGOs, and physician healthcare community at large, I think is something that has evolved a lot. And that is very important. This is coming from the ecosystem and the pharma industry, but it's also coming from the regulators, by the way, where regulators are asking more and more to have patients involved in the development of medicines. even to have patients sitting at some advisory committee of the regulators when reviewing the medicine and approving them. Then another parameter is, of course, affordability. Medicines and innovation is expensive. It is in the hundreds of millions of dollars to develop, potentially even in the billion of dollars. And the more science progresses, the more targeted we are on the disease. So if we speak about AML, some of the gene mutation, they're going to address 6-8% of the patients suffering from AML. So AML by itself is not a very large disease, hopefully. And then within that, you address only on a very small population, and still you have an important cost in front of it. So unfortunately, the costs of treatment are expensive. Delivering better and better results, and year after year, we see improvements in terms of the therapies that are brought to patients at large, and this is great. I think the companies are trying to do, in a way, as much effort as they can, especially when it comes to India. We know that there are people that can afford, but there are also many people that cannot. And that beyond the drug treatment, you have the testing, you have the hospital stay, you have the overall financial burden to handle the disease that is massive. So when we look at the cost of medicine in India, it is within a number of times cheaper in India compared to Europe or to the US, and this is good, and that's the right thing to do. So that goes with a patient assistance program in particular, either for the medicine, either for the testing, also with support and many kind of financial support when till to the maximum in terms of improving the affordability of the medicine. Finding new medicines that are great in delivering benefits to patients is beautiful, provided many patients can benefit from it, right? So I guess this is where our role is important, to try to make medicines as much affordable as we can.
Amazing. Quite insightful, Mr. Breton. I'll come back to you, Dr. Ashay. Dr. Saab, like we do talk of a lot of solutions, like, okay, so when this thing is coming from people or the government outside, let me be blunt about it, or people who are not into it, okay, this is to be done, I don't know who advises them and how it goes to, but you as a clinician, what do you think could be the possible solution in 2-3 possible solutions that would kind of exponentiate the access, educate the primary physician, because early referral is one of the pain point that we had been discussing about. And the mass awareness at patient level or the general level as well.
Yeah. So, as Mr. Breton also pointed out, your lack of awareness or the lack of education is. So you have 2-3 points where we can have. So first of all is a mass education. So mass education, definitely when you have many things, like now there is a liberty, you choose whichever stream you want. You have a science, you have arts, you have commerce. So like we have like civic sciences basically, so the thing is that at the, you would have heard a lot of time now, like India probably is considered a taboo, but even a sexual health also has been, now the part of the curriculum, which was hardly ever talked about. I mean, it was never spoken about when I was actually a student.
Yes.
But now that is something which is they are discussing. They are discussing about, good touch, bad touch. If I ask my 7-8-year-old daughter, they would be taught about all these things. So I think the change is made by the education itself. So we can have, like basic healthcare, how it should be, and other things. First of all, as all the citizens of India, basically when it's a basic curriculum, you taught about the basics. I'm not saying AML, AML is not something, but what exactly is the cancer and other things, because they will have a lot of things to opportunity. Next level is, the healthcare sector. If you really look at the health sector, probably there will be many villages where will be not even proper doctors. So in India, you have, these multi-purpose workers or social workers, which are actually taken up from the community. If you look at, in India, previously the malaria program or the TB programs, or even the child and maternal mortality, many of these things are taken care of by these paramedics, not even the medico, I am saying. So even if you have the access to, like all these things. Fortunately, even I will say, like, I mean, I always find it, very wrong, like whenever we say, these MNCs, when they introduce, okay, it's so expensive, and Mr. Breton pointed out, average, if I start in a laboratory 400 odd drugs, only one of them reaches the market. 399 are discarded. Discarded means they will probably be failed in the preclinical studies or the animal studies, or if at all they reach a market, some side effects pops out, plus they need to be compared with the standard drug of that time. So actually getting the approval of a drug, the chance is 1 in 400. When you actually take 400 odd molecules, start working out, so the cost is whooping. $100 million odd means it's, I think is maybe telling a lower margin of that, but then it's very whooping. So technology accessible is one part of it, but who is going to R&D about it? But somebody has to do research. You cannot have, the way we are saying precision medicine and other thing. Who is going to do the research? As clinicians, we are not doing the research. Where somebody has to fund that research, and somebody has to bring about the new eras in science. So, and that is something which is inevitable. But I will tell you, whatever the technology, once you start using it, it becomes cheaper. That's what I told you. The NGS, first time somebody had done the whole genome sequence for $100 million. Now you can do it in 10,000 rupees, 25,000 rupees, 40,000 rupees. So the more you use, the more it becomes accessible. So that is something which is, so we have to make it aware, that the pricing of the drug is beyond sometimes the control. You have to be a long sustenance. You cannot do a charity if you have not considered all the economics about it. So that is something which is more vital. So training. And the third thing is that I have been a part of certain pharma initiatives where we are going to a different rural areas or district areas. We are conducting a CMEs basically, through which we create all this awareness. So I'm not for AML, but early diagnosis of cancer, when to refer. So there are certain things which are done also about it. So I think if we could have all possible solutions, because see, everything you cannot really put on government, government is not going to provide you everything. I think people like Amit who come forward, or pharma industries come forward, I think they play their own role. And I think the era is there, you have now, I think India, we are, thankful that we have easy access to data. Everyone has a smartphone, and data is quite cheaper if you compare to actually EU and US. Correct. It's much cheaper. So the thing is that we have access to it. And so I will give a simple example, how fast and like India is a huge country. So that time I was a student leader and things, so it's way back when in my medical days. So I've, printed one message for all medicals, because some nationwide agitation of doctors was going on. You won't believe, within 1 hour, I got the same message back from Kerala. I was in Mumbai, so it got circulated, went into that community, and within 1 hour it was back. So social media is a tool, it's a weapon. You can use in a positive manner or negative manner, but I think we could use this, because you see, like you get some nice video forwarded, and you will have 10 different groups forwarding in the same day. So if you have, social media, you can use as a weapon, for positive things, negative things, whatever you want to. I think we have now that era where you can have this lot of awareness coming out of all these things. Yes, somebody needs to come forward, like your social entrepreneurs like you, who can come forward, take these initiatives. Now we have self-support group. And sometime back when I was discussing, like when Amit was telling, what after getting cured, So, and even Mr. Breton pointed out, we are just having PFS and OS as a time points. I don't think so. That is something right. What life I have given after? That sometimes, because I, being a transplant physician, I am asked myself, I was very happy, like I transplanted a small girl in 2007, and, last year I attended a wedding. It was nice. Actually, I traveled to Pune to attend her wedding. But when I look back, because still in our society, it is considered you are living a normal life if you are getting married, you are going to have kids, and you will have stable job and other things. So unless you have done that, you are not leading a normal life, or you have not achieved anything. Oh, but we have to understand, after transplanting, as he said, he had some erectile dysfunction, there's infertility. So there's a way to overcome this infertility, and we need to change the perspective, that as a human being, because I always tell, as a doctor in my clinics, I spend some time, I have cured the patient, but when you actually go back and try to see what exactly is happening in their life, is something which is, you have to ponder really, like what exactly is happening out there. Means, are they leading a normal? As he said, he's jobless for so many years. So because that means that, I've cured him of one illness, but I've given him multiple illnesses. I always say ki I have made something, which was life-threatening into illness which is going to, slowly creeping inside. So that is something we need to change over the period of time. I think the solution is just not ki how I will make treatment accessible, but after getting cured, how can impact their life? That is something which is most important.
Thank you, Dr. Sir. Amit, I'm coming back to you, and I would like to know that how much do you think that a patient support group specific, because all the cancers are different. Like, we run multiple support groups for multiple cancer domains, but AML having a support group of its own, which is nationwide, which is unbiased, which is agnostic to any or every kind of attachments, would be of use, because you mentioned that there were navigational challenges for you.
Yes.
There are challenges while coming back in this mainstream the society. Dr. Saab has mentioned about AML has become or AML has been cured, but there are multiple things have cropped up.
Offshoots.
So how do you think that a support group or something like that would help? Would it be real? Because there must be a lot of challenges or complications why it has not been done yet, or it has been done at some local or regional level. So what is your opinion about it?
Okay, so when I was getting treated, I was not part of any support group. The only information I could get was from WebMD, Mayo, and Sloan Kettering articles as to how my disease is progressing and what is the best way ahead.
And not everybody is capable of understanding WebMD or Mayo Clinic.
I agree on that. Thankfully, I had a technical background, and as a result of that, I could read through. My wife still told me, don't read so much. I said, I need to get informed because I don't have anybody informing me. I used to discuss the articles with my doctor. Thankfully, my doctor was reciprocative. He was reciprocative. Not many have the privilege of having a reciprocative doctor. I have had a couple of friends who have said doctors are very old school. They don't want to listen to the patient. If I prescribe you a particular drug, take it and keep your mouth shut. Be thankful that you're surviving. I don't want to name the doctors, but there are doctors who say this. So, when you talk about patient support groups, I was among the selected few by National Cancer Grid of India and NGO named Patients Engage. So they came up with a program wherein they were training, this is India's first batch of 14 people, trained as patient advocates for clinical research. So I am one of them. I am one of the selected few from the batch of 14. We recently had a CRIDA workshop wherein aspiring medical oncologists of India and abroad are part of a workshop where they discuss various new drugs or methodologies in order to detect and cure cancer. I'm thankful I got a lot of knowledge from them, and I wanted to do something in this background. I mean, when it comes to crowdfunding, people gave something to me for my treatment. I want to give something back as patient education, being their navigator, and being with them in their troubled times when there is no one to look for them. So a support group, as you rightly said, is the medium on social media which can actually make a patient's voice heard. I mean, the patient support group can also get connected to various doctors, and their advice also can in turn fasten the process of relieving mental tensions among patients. That's what I sincerely hope when a patient support group comes into existence, that thing should happen. I mean, I was part of a clinical research, and I was part of a clinical research. I was one of those candidates who took part in clinical research. My treatment before the transplant was part of a clinical research, CIB-MTR clinical research. And I was made to sign an informed consent form. The nurse said, just read through it and just give me a signature. I said, let me read through it. Because none of the staff is sensitized enough to even tell you what the long-term side effects could be. Which is important because you don't want to go back home saying that, "Arey, I didn't know this could happen to me." Agreed, chemotherapy can lead to nausea, diarrhea, vomiting, but certainly not somebody having a weakened heart because of the chemo drugs. Because most of the chemotherapy in AML happens through a PICC line that directly goes to your heart, and the heart in turn pumps it through the entire body. So there have been cases of weakened hearts and complications happening because of that. And yeah, chemo, radiation, all those. So during the workshop, I read something about a inferiority trial, wherein a high-level chemo radiation is not given, but suboptimal doses are given over a period of time in order to give you the same kind of effect, so that your body doesn't go to a high extent of getting a load of chemotherapy and radiation in one go. Those kind of trials are preferable. There needs to be good treated patient data acquisition in order to understand what the future drug, what do you say, development can take place because of that. If and there are places in outside India where patients, as patient advocates, are allowed to be part of clinical trials. And their voice is part of the clinical trial right from start to finish. So in the US and UK, there is something called as patient reported outcomes. That's not the case in India. The patient doesn't know what to report. So data acquisition with the help of quality of life questionnaires will help assess the patient's health post his treatment.
So I got my answer that the support group in AML is absolutely required, not only from the navigation perspective, but to make people or the survivors lead a normal life and get back into the mainstream. Just to sum it up, like we understood, like there is absolute need for the physician awareness. There is absolute need for the mass awareness. There is absolute need for the building an ecosystem and clinical trials and everything. And Aurelien is known as or kind of, it means golden in French, if I am right. So it's a golden opportunity for me to ask you or learn from your take on your commitment or Servier's commitment in India in terms of education and access of AML treatment.
I think absolutely. Being at that table, I think, is the first step of showing it. I think hearing what you saying in terms of you wish to give back to the community, to give back to the patient going through what you've gone through in the past is emotionally very strong and very appealing. That's clearly our commitment as a company to work with NGOs, to work with patient associations, to work with physicians, specialists or high-end specialists, but also primary care, secondary care specialists in order to improve the diffusion of knowledge, awareness, in order that physicians are more capable of identifying the right first symptoms, actually blood count, and referring more rapidly.
Thank you so much, Mr. Breton, Dr. Ashay and Amit, for opening your heart and providing the insight that are really commendable, and it's very grounded. Like it's coming straight from the heart. and we see a lot of scope in terms of building an ecosystem for AML, right from awareness to access to rehabilitation. And I'm sure that we'll work a lot on this, this topic or this area or this domain. And I believe that this discussion does not end here. It will continue in multiple formats, or probably like we will do more work to educate more number of people. We would have more stakeholders, and hopefully someday we would come up with some policies change, which would kind of make the lives of patients and survivors' life better in our country. And I'm seriously thankful and grateful to all of you for having your time out and having this noble discussion on this task. Thank you so much.
Pleasure.
Thanks to you. Thanks to you all.